Test, test, test.
Okay, welcome to this meeting of the County Council's Health Scrutiny Committee on the 9th of July 2026. Feel free to take pictures and use social media during the meeting, but please turn your phones to silent or vibrate so we don't have any unexpected interruptions. The meeting will be live streamed and a recording will be available to watch later on the Council's website. There is no fire alarms test scheduled for today, so if the alarm does sound, I'll adjourn the meeting and we'll leave via the side doors and use the fire escape next to the kitchen. The assembly point is at the far end of the car park. The committee is joined today by Jess Slater, the Chief Executive of Healthwatch, Cambridgeshire and Peterborough. Healthwatch is not being scrutinised today, but has a standing invitation to contribute to all of our health scrutiny sessions. Yes, we're also joined this morning by a group of work experience students who are observing the meeting today as part of their week with the council. It's good to have you with us. Welcome. So we'll start with agenda item 1, which is the notification of the Chair and Vice Chair of the Health Scrutiny Committee for 26-27 and changes to the committee membership. Would the Democratic Services Officer report these, please?
Thank you, Chair. Councillor Liam Beckett succeeded Councillor Dupre as a committee member on the 15th of May 2026. Councillor Dupre replaced Councillor Young as a substitute member of the committee on the 15th of June 2026. Councillor Beckett was appointed the chair of the committee for 2026-27 by Council on the 19th of May 2026. Councillor Fain was appointed the vice chair of the committee for the same period by Council on the 19th of May 2026. And Councillor Wells was appointed a substitute member of the committee on the 21st of May 2026. There's one additional appointment to report since the meeting agenda was published. Councillor Stephen Fisher was appointed as a member of the committee on the 3rd of July 2026.
Thank you. May I also just take this opportunity to thank Councillor Dupre for her contributions to this committee and extend a big thank you to Councillor Howard for all of the work that he has conducted in this committee over the last few years. Moving to item 2. Item 2 is the appointment of non-voting co-opted members of the committee for 26-27 to represent our district council partners. Could I just ask the nominees to briefly step outside of the meeting room for this agenda item, please? So we are asked to appoint the following district councillors as non-voting co-opted members of the committee for 26-27. We have Councillor Catherine Hubbard of South Cambridgeshire District Council with Councillor Corinne Garvey as substitute member. Councillor Alex Boulat from Huntingdonshire District Council with Councillor Stephen Claffey as a substitute member. Councillor Dr. Haq Nawaz of Fenland District Council with Councillor Mrs. D. Laws as substitute member. And Councillor Keith Horgan, East Cambridgeshire District Council. We're currently awaiting Cambridgeshire City Council's nominee. If there are any objections to these appointments, please could you just indicate that now by raising your hand? Thank you. I take it as those appointments are approved unanimously. Could we ask our co-optees to please join the committee? Would you like to take your seats at the committee seats, please? Thanks. Okay, so the appointment of our non-voting co-opted members was approved unanimously. Before we move on, I'd like to place on record the committee's thanks to Councillors Corinne Garvey, Mike Todd Jones and former Councillor Ben Pitt, who served on the committee as co-opted members last year, and in Councillor Garvey's case for the past 5 years. Their contribution is very much appreciated. So, as we have several new members, including myself, I propose that we briefly go around the table and just introduce ourselves so that everybody is clear on who is present and what everybody's role is on this committee. I'll start and then we'll go around the table from my far left, starting with Councillor Howard. And I should add as well, just to be heard, you will need to press the button in the middle of your microphone and make sure you turn it off once you have finished speaking so that the camera doesn't linger. So I'll start. I'm Councillor Liam Dewey-Beckett, a member of Cambridgeshire County Council, and I'll be chairing the Health Scrutiny Committee this year. My role is to make sure that we not only keep to time, but to run these meetings well and make sure that our scrutiny is effective, that we follow up on recommendations and develop a work programme for the year that represents our residents and the needs that they have. Councillor Howard.
County Councillor Richard Howard, I represent the Petersfield division in Cambridge.
Morning, Chair. Councillor Keith Horgan from East Cambridgeshire District Council, representing Salem North is the ward.
County Councillor Stephen Fisher, representing March North and Waldersea.
County Councillor Sarah Kane, representing Sydney's East and the Grandstands.
Good morning. I'm here with a different hat back on the committee as Huntingdonshire District Council member for St. Ives South.
Good morning, Sally Cartwright, Director of Public Health.
Good morning, Patrick Warren Higgs. I'm the Executive Director for Adults Health and Commissioning at Cambridgeshire County Council.
Good morning, I'm Peter Fain. I'm the County Council member for one of the members for Sawston and Shelford Division, and Vice Chair of the committee, in which my role is just to support the Chair in the role as described.
Good morning, I'm Rashenda Greenhill. I'm a Democratic Services Officer here at Cambridge County Council.
Good morning, I'm Catherine Hubbard. I represent South Cambs District Council. My ward is Hardwick and Toft.
Good morning, everybody. My name is Jennifer Malinowski. I am a county councillor representing Burwell in East Cambs.
Good morning, Dr. Nawaz, representing Fenland District Council. Thank you.
Yeah, as you heard earlier, I'm Jess Slater from Health Watch.
Thank you very much. We'll move on to item 3, which is apologies for absence. So, and declarations of interest. So would the Democratic Services Officer report any apologies, please?
Apologies received from Councillor Martin.
Thank you. Does any member wish to declare a disclosable pecuniary interest or non-statutory disclosable interest in any of the agenda items? Okay, thank you very much. Agenda item 4. Item 4 is the minutes of the meeting on the 24th of March 2026 and the minutes action log. The committee is being asked to approve the minutes as an accurate record. Are there any objections? We'll come on to actions from the minutes later if you...
Thank you, Chief. Just wondering, there was a question I raised about the GP patient ratios. Maybe I missed it, but I didn't see it in the action log or the tracker. Could you kindly double check, please? Thank you.
Rashenda?
Thank you, Chair. I'm very happy to check that, Councillor. And if it's missing, then I will make sure that's picked up in the action log. Is that okay?
Yeah, thank you very much. They were supposed to come back with those figures. And thank you.
In that case, then, can I suggest that we approve the minutes as they are, subject to that addition coming back separately? Is that okay? Yeah. Okay, so I see no further objections, so we'll take the minutes as an accurate record, and I will sign them now. So we'll turn to the minutes action log, and I've been given notice of some questions of this that we would like to take now. Councillor Nawaz, I believe you had some questions on the action log.
Yes.
Relating to Palantir. Yes.
Thanks. Yeah, one was the Palantir issue, page 45, and the others on the dental school at the Anglia-Ruskin University, Peterborough, page 43. These date back to, I think, last year, towards the end of last year. There was also one outstanding item, which was the men's health. This was supposed to reflect the concerns which were highlighted during 2025 about prostate cancer and the testicular cancers. So these, I wonder if there is any meaningful update. I know there is something on Palantir, but that's quite sort of meaningless. It's a non-answer, and so is the dental school at ARU, which I'm sure your predecessor is well aware of, and he was very supportive. And if I may take this opportunity, Chair, to thank your predecessor, Richard. I thought he did a sterling job, particularly towards the end. We really were making some headway, and I'm sure we will continue along that path. Thank you.
Thank you. Patrick.
Yeah, thank you. And through you, Chair, we've taken that action to make some contact with you outside of this meeting. So we're going to try and get time with you to work through the specific details of the questions that you want clarity on. And then we'll work back through the Chair to make sure that committee are comfortable with those lines of questioning. And we'll then approach those organisations to ask them for further detail, which hopefully will satisfy your lines of inquiry.
Thank you for that. Just one more thing was the Section 106 monies. Given that there are so many housing developments and inevitable increase in population without commensurate increase in the NHS facilities, and Section 106 monies are very important in that context. And I did ask the question whether they are statutory consultees or not, and I think they are. So what is the way that they work out these monies? What is the formula? How much monies have they received, and how they're being, basically, if you like, the NHS side of the Section 106 monies. If you could possibly deal with that as at your convenience, as you deem appropriate, please.
We can certainly pick that up when we meet with you and just get some clarity on those points, and we could wrap it all up so we've got understand all of the different lines of inquiry that you're wanting some further details on.
Thank you.
Thank you, and thank you for raising it. I think that accurately reflects the concerns of many residents, so I appreciate you raising it. And as Patrick has described, I'll make sure that the committee is aware of the discussions that were ongoing, so you have oversight of that conversation. Thank you. So we'll progress those actions as discussed and take the minutes action log as noted. So just to update the committee, I'm aware that on item 5, our representative to be scrutinised is currently stuck in traffic. So I propose that we move to agenda item 7. Which is the health scrutiny recommendations tracker. So could I take, are there any comments from the committee members on the responses that we have received since the last meeting? No, very good. So we'll take the recommendations tracker as noted. Thank you. And as we still don't have our representative, we'll move on to agenda item 8. So this item of business is the health scrutiny work programme. So since the March meeting, we've received written responses from all of our local NHS trusts about their business continuity and emergency planning arrangements. These were reviewed by the head of emergency planning at the County Council, and currently there is no further scrutiny planned at this time. And members will be aware that today's session was originally going to be on cancer screening. This has been deferred until the next meeting, so we need to identify a second scrutiny topic for October. We'll also be reviewing our statements on our local NHS trusts quality accounts for 2025-26 at that meeting, and looking at how stakeholders' feedback is used. Yeah, and during that meeting as well, I would look to our members who took part in the task and finish groups, which reviewed the quality accounts, to lead on that discussion. Looking further ahead, we've invited the Chief Executive of the Integrated Care Board back in December for a follow-up. Oh, is that not today's agenda item? Oh, okay, thank you. So yeah, looking further ahead, we've invited the Chief Executive of the ICB board back in December for a follow-up session on the ICB cost reductions and reconfiguration after a year since her last visit. We previously identified winter pressures on the NHS as a potential second topic in December. Bearing all of that in mind, are there any comments or questions on the scrutiny work programme? Councillor Fane.
Chair, perhaps I could kick off. We're looking for a second scrutiny topic for October. When we look at Fit for the Future, the government's programme for the next 10 years, it does inevitably place a lot of weight on the role of GPs. And whilst we have had some discussion of that with GPs representatives, we, I think, also can expect that there may be some amendments. We have a new Secretary of State for Health already. We are reasonably anticipating a new Prime Minister. There may be some changes, and therefore, I don't know whether people could hear me, but therefore I think it would be reasonable to have further engagement with GPs representatives to see to what extent they are able and willing to take on the obligations being placed upon them.
Councillor Noirs.
Can I just welcome that? This is something that is absolutely necessary, even though in the previous meeting, director from the ICB, Director for Neighbourhood Health, stated that this is more or less irrelevant as they have reorientated the teams within the primary healthcare. However, Dr. Booth, that you may, Councillor, be referring to, he absolutely agreed with me that it was a crucial metric to measure the quality of treatment, as well as a measure of how the waiting lists are performing. So I look forward to that, Councillor Wayne. Thank you.
Thank you very much. I think that's absolutely appropriate, and if we could add that, so we'll come back and have a look at that work programme and discuss whether we can add that into the meeting. But that sounds like a useful topic to scrutinise, so thank you both. Councillor Malinowski.
Thank you, Chair. Thinking about the future work programme and things we might want to look at this committee, obviously you've mentioned that we'll be looking at winter and the effect winter pressures have on the NHS. I do wonder whether, maybe potentially not for October, but as a rolling item going forward, it may also be worth looking at summer, based on the fact that over 800 people have died in the UK during heat waves in the last couple of months. This must be putting an extraordinary pressure on NHS services, especially in this county, which is obviously a very dry, very hot county. And I just wonder if it's maybe worth us thinking as a committee about how we might want to get into that and the effects of that going forward.
Thank you. I think that's a really appropriate topic, and I can completely sympathise given the circumstances. So yeah, we'll have a look at how we can plan ahead and take that topic into consideration. I'm not sure right in this moment how we'd kind of collectively do that with one or two guests, but I'm sure we can discuss that and figure that out. Councillor Boulat.
Thank you, Chair. I really welcomed when we had back in December 2025 the scrutiny session on the provision of NHS dental services. I think it's a topic that still remains very important for all our residents, and I did welcome some of the outcomes of that. I'm not sure if this is a topic for this year's program necessarily, maybe for a future briefing note or something that members could be involved. But one of the issues I was really concerned was raised with me recently was the underspend that was reclaimed by the ICB from the NHS dental contract and how that funding is used. So I was wondering if we can have maybe like a report or some way to engage in terms of like having scrutiny on actually examining the NHS contract underspent in our area and how this money can be reinvested in providing service for our communities. I have some information. There were some freedom of information requests on the exact numbers, but I think I want to bring this up as a topic because I know it's very, we had motions at council, we had previous health scrutiny sessions, and it's a topic that many of our residents are concerned, especially if they don't live close to accessible dental services. Thank you.
Thank you, Councillor Boulat. I know that this committee has scrutinised dental services in the recent history, but I'm also aware that that topic may not have come up in that committee meeting. So what we'll do is review that, and if it hasn't, take that into consideration and prioritise it as appropriate on the work programme. Thank you for raising it. Councillor Kane. Sorry, Councillor Rigby.
I've got two areas, one very close to my heart, and something I bring up all the time in sort of the adults and health is the obesity levels and the fact that when we look at our rag rate and it's the one that we're not able to, we're still in red for and we seem to not be sort of hitting those. And I think there is we've got a real epidemic and a real danger in terms of childhood obesity. I'd really like to see us do a bit of scrutiny about what the council's doing and what we can do to sort of improve that. That was my first one. On my second one of sitting as the sort of the appointed governor for CFPT, I see quite often the impact of mental health and the mental health provision. And I think that is one of the key areas with the ICB. It's 5 pillars. I'm quite concerned about how that is progressing. And I think a little bit of scrutiny on mental health would also be welcomed.
Thank you, Councillor Rigby. Yes, those are good topics to add into the work programme. And also, we'll discuss them as a team and have a look at that. And thank you for raising it. So it appears we don't yet have Pam from the ICB. So could I suggest that we temporarily adjourn until 10:30? So if you could please come back at 10:30, and if Pam isn't there, then we'll discuss what we do next. Thank you. Okay, thank you, members. So item 5, going back to item 5 on the agenda, is an introduction to the Central East Integrated Care Board strategy, which is called Our Way. We are joined for this item by Pam Green, the Director of Partnerships for Cambridgeshire and Peterborough at Central East Integrated Care Board. I'll ask Pam to introduce the report, and also, given that a number of committee members are fairly new to health scrutiny, I've given advance notice that it would be helpful just to get a short overview of what the ICB is, some examples of its impact in Cambridgeshire, and Pam's role. Pam, over to you. Thank you. There's a button that looks like a face in the middle of your microphone. If you press that and it goes red.
Oh, that's a button.
You've got it.
Very tech. Hi, sincere apologies for my delayed arrival. There was a lorry broken down at Newmarket which stopped everything from moving. So yeah, I would not normally be this tardy. I am Pam Green, as the chair's introduced. So I'm the Director of Place and Partnerships for Cambridge and Peterborough, and importantly neighbourhoods, which is our new strategy of delivery. The role of the ICB, so you will have had colleagues that have come before me here and presented. In fact, I've been and recognised some of you from coming before, but our predecessor organisations were NHS commissioning organisations, PCT, CCG, ICBs, STPs somewhere in there, and now ICBs in the format that they are as strategic commissioners. So the health bill indicated that there would be a change to the role of ICBs to revert much more to commissioning and contracting payer-payee function oversight, as opposed to the convener of partners in the system. So our fundamental role is to mitigate health inequalities through the commissioning of health services that meet the needs of our population, and underpinning that contracting with the appropriate services and providers to ensure that we deliver best value for the money that we receive for health services across the piece. So Central East now, ICB is the combination of what was Hertfordshire, Bedford, Luton, Milton Keynes, and Cambridge and Peterborough predecessor ICBs. So it's a very large organisation. It's the second largest commissioning organisation in the country. We serve 3.5 million population, and the net income that we receive to do that is very sizable. So £8.5 billion budget for health services across that population. So it's no small feat trying to organise that. Since the declaration that ICBs should cluster and reduce their staff base by 50%, we have been going through an organisational restructure, and we have completed that now, 90% of it. So what you now have is a structure that services Cambridge and Peterborough, that work with colleagues like Patrick and Sally as officers to design and deliver integrated health with partner services as well. So the neighbourhood agenda is very much about health services catching up with local authority design and delivery, I would say. It's not a new concept. You've been working with communities for a very, very long time. I think health has always had sort of slightly different infrastructure and been quite hospital-centric. The neighbourhood plan, I believe, is the first real indication that we are much more about primary care-centric delivery, working right into communities with communities and delivering best value for them. So that is our prime function, to commission and deliver better outcomes for the population and mitigate the health inequalities, to work with a health and wellbeing board and yourselves as colleagues to ensure we get that right. We have the voice of the population in that design and delivery, and very importantly work with general practice, optometry, dentistry, pharmacy to ensure that that high street aids accessibility for our populations to have best health closest to them. We have set some priorities out very clearly in our strategy called Our Way, and the Our Way document is very much a commissioning document that indicates from our population health data, which we'll come on to talk about later, I'm sure, what the highest priorities are within the population of Cambridge and Peterborough and across Central East. And those priorities are really about ensuring that we deliver best value, making sure that we enable access to be easy and effective. And I'm sure this is a priority that you would relate to, but making sure that we keep our population economically active. It's the single biggest determinant of good health outcomes. If we've got people in meaningful work and supported and having purpose. So that means everybody, so anybody with long-term conditions, etc. How do we get Britain working in that way? And the clinical areas of priority are we've got 5 areas that I'm sure won't be a surprise, but they are musculoskeletal, so physical presence and the pathways associated with that. That's very, very significant when we're talking about working populations to ensure that people are physically able to work. Mental health, young people's mental health and crisis. Also cardiovascular disease, ensuring that we have got really good diabetes pathways, dermatology pathways, the things that create significant volumes of activity within our system. Neurodiversity is something that we've talked about here before, so making sure that we've got a strategic approach to neurodiversity, and taking a reduction of utilisation approach to that. So making sure we're working from our care model, which is from prevention right through to crisis. So in every one of those topic areas, ensuring that we've got a complete plan. The delivery model for this is absolutely through integrated neighbourhood teams. So the integration of health, social care, communities, voluntary sector to ensure that we've got services that really support our population and don't expect our population to fall in line with organisational structures, and we become more centric to the individual. So personalisation is a very key element to that. So I'll stop there because I realise that's a lot of information in a very short amount of time. I'm happy to take any questions.
Thank you, Pam. So I'll now open the scrutiny debate. I'll begin by taking questions around the 3 main lines of inquiry that we identified during our pre-meet. And just for everyone's benefit, these are the ICB's priorities and delivery, ICB finances and patient care. I'll take each topic in turn, if that's okay with the committee, starting with the questions on priorities and delivery. I'd encourage committee members to consider whether they are reassured by the responses that we receive and whether there's any further feedback or recommendations that we can provide thereafter. By the way, I'm also happy to take comments and feedback from the Chief Executive of Health Watch at any point during the debate. So, members, do we have any questions on the ICB's priorities and delivery? Councillor Thane.
Yes, perhaps I could start this off. Thank you for that. You referred very much to the neighbourhood as the basis for delivery.
Yeah.
But I think the neighbourhood in this case is Cambridgeshire and Peterborough. It's more local than that, is it? Yes, thank you. Because I think there was reference to the creation of a, give me a moment.
Neighbourhood Delivery Committee.
Neighbourhood Delivery, thank you very much.
I can explain the
that would be helpful.
Governance of that, if that helps. So neighbourhoods are very much, the evidence tells us that working in populations of 30 to 50,000 gives us the greatest level of ability to influence continuity of care, so the join up and overseeing of care. It's no accident that that comes from the alignment to primary care networks, where groupings of primary care networks. So our de minimis level really of delivery should be at 30 to 50,000 population. And I think you would probably see that that's the way that people see the way that they live more so. And they may live in subsets of that neighbourhood, but generally you can relate to that geography as being something that aids accessibility, has assets within it that people can access more easily than having to travel across the county. So 30 to 50,000 population would be the way that we would create teams, work into general practice through their neighbourhood working that has been very much rolled through the primary care reforms over years since the development of the additional roles that have been seen in general practice. And the Neighbourhood Delivery Committee is a governance structure to give us a local decision-making forum, a subcommittee of the much bigger ICB board. So whilst we will employ an 80-20 rule across Central East to get the most effective delivery, the most evidence-based delivery, that committee enables us to make sensitive decisions for the populations that have different needs. And that is, as an officer, I've got the accountability to deliver that committee and ensure that our delivery relates to the population needs of Cambridge and Peterborough.
Thank you. No, fine. Councillor Howard.
Morning, nice to see you. 3 questions. I did want to ask about neighbourhoods, so I will put that one in, although it could be under both themes. The first one, is always easier to talk about the extra priorities and obviously more difficult to talk about what you're going to do less of. You have put in the strategy that you're going to do less on MSK, on diabetes and on dermatology. Is there anything else that you're considering doing less on? And in lay terms that patients can understand, if you have diabetes, what are you not going to get that you do get today? That's the first question. The second one is on integrated neighbourhoods, as Councillor Fane has raised it. I'm very concerned that although all the language is right, that the money is still going to go to the acute trusts. So I'm not convinced from what I've heard that you're going to seriously fund the integrated neighbourhoods. So reassure me. Tell me why I'm wrong, because I think the acute trusts will just do local delivery under their management and their services rather than money genuinely create integrated neighbourhoods. I'm worried about that. And finally, no, it's a finance question, so I'll wait, Chair. Sorry.
Okay, so things like diabetes and dermatology, we've brought together a system that has got many acute trusts within it. So, 8 delivery points within that. They've all got slightly different pathways. They've all got slightly different models. And what we're picking up through working across the piece is actually what is the best practice pathway from all of that learning that gives us the best possible model to deliver and deliver across that geography national best practice models that have not been implemented already. So I've led on diabetes for a number of years in different parts of the east of England. And what I would say is we need a very much more primary care centric diabetes model that enables that continuity of care to happen closer to the population. It delivers better outcomes. It is now the national model and that needs to be implemented. So it's not doing less outcomes, it's doing less consumption of resources to get to that point. and it will be doing it in a more considered and commissioned way, so that we don't have completely different services, but we've got the ability to sensitize those services to the population. So if the populations in Fenland need to access diabetes through a community centre because the services need to go out to outreach to be able to get a better engagement, the freedom is there to do that. So by prioritising them, we're saying we will get the best practice model in, we will use the provider models that and collaborations, we will strengthen and support primary care to have a better role in that, and we will get a better uniform kind of delivery model that enables equity across our population. So that's what that means. From a finance perspective, we have a duty to invest in neighbourhoods, and actually the neighbourhood delivery evidence shows us that it's a lower cost base than delivering the care through acute hospitals. Acute hospitals lose money on every single outpatient attendance that they have. It's been incentivised nationally to shift through those that investment out into neighbourhoods, and we are responsible for ensuring that it is not just a delivery of services under an acute hospital banner. They have a very important role to enable their consultants to work more closely with primary care. There's a lot of national incentives to do that, and it is our role to ensure that that happens, and it happens equitably across our population. So have I reassured you? Maybe not, but I will absolutely bring the evidence of that back to this committee.
I don't think it passed the patient test, your first answer on diabetes. I hear it and I understand it myself, but I implore you to be, not you personally, but I implore the ICB to be very transparent when you can't do things, rather than hiding them in any way, because I think what you're saying is you can provide the same service for less money, or even better service, you hope, but you can't say that about everything. Sorry, I don't want to, I've lost my train of thought for a second, I apologise. On the other point that I raised about neighbourhoods, would you commit to writing to us afterwards saying what the funding you think is needed, or the ICB think is needed for an integrated neighbourhood? And I will just slip in, at the Adults and Health Committee of this council, they've set up a draft contract for domiciliary care, which doesn't have the same boundaries locally to the integrated neighbourhoods, and I criticised that at the time. Can I urge you to talk with this authority, because it seems absolutely stupid to me to have integrated neighbourhoods and then the authority having different boundaries to our health partners. So can I urge you to talk with the authority about that?
Yeah, absolutely. I would take both those actions.
Thank you. Councillor Horgan.
Thank you, Chair. Hi.
Hi.
I've got two questions. I don't know whether you want both of them and you're going to try and remember them, or... Okay. Broadly speaking, one is about commissioning decisions and the other one is about data sharing agreements. And so the first one, I'm interested to understand how the ICB will demonstrate that quality is our strategy is driving real commissioning decisions rather than being a branding statement. And the second one is, what specific data sharing agreements and technical systems will be or are in place to enable real-time information flow across primary care, community, mental health and local authorities? Thank you.
Do you want to take those separately and start with the first question?
So the total quality management approach that we have taken as a new ICB is novel. So the structure that we have designed in our organisation, the fact that we have got clinical leads for total quality management, as opposed to a traditional chief nurse, is very, very different to what you will see across the country in ICB. So it is a very bold statement that we are putting quality at the heart of everything that we do. So we are taking a continuous improvement methodology in everything that we are doing. Every one of those priorities are being designed with our population. So actually it's not about organisations, it's about citizen voice, it's about clinicians' voice, and actually listening to what they want to hit, the change they want to make, and us being able to iterate it, test it, and scale it across our population. That is, having been in commissioning for 17 years, I think now, and a clinician myself, that really rings true to the way that I would make clinical change in my clinical practice. And what that is it's novel to do it on this scale. I absolutely accept. I don't think people in the before us have actually said we will commit to working in that way for all of our changes, and it is going to be clunky. And Jess will work with us to make sure that we get the citizen voice running through those changes in not a tokenistic way, in a very different way. We're working with organisations that have done this across the world, and we have invested in our staff to change their way of thinking to enable a very different approach to quality management. So I believe it is not a statement. I can tell you, it's not a branding. It's absolutely a way of working. And I think it's the way of working that will deliver greater citizens' voice through the changes that we are making.
If I may just quickly press you on that, actually, because I think that's quite an important question. I'm unfamiliar with these roles of the quality management leaders that you described. Could you just explain why are these roles more value for money instead of the ways that other ICBs would typically work?
So most ICBs will have a medical director and a chief nurse, and they were statutory roles. Those roles for Central East ICB are now known as medical director for improved utilisation, so reducing the amount of waste that we have in our system, and the clinical lead for which one have I done? Utilisation and total quality management. So it is a very, very different statement around how we are working and the remit that they're doing. So they're not doing a traditional role that just says we will lead our medical community, we will have traditional quality processes in. They are leading with their clinical experience the change that attunes much more to the population's voice and to the clinician's voice within the system to get the right answer as opposed to the protocoled answer. So it is different. And in fairness, I think people are still writing to us saying, can you tell your medical director this? Or can we speak to your chief nurse? Because it is unusual. But we're absolutely committed to working in that way and have invested a lot of time and our leadership style. So we were recruited on the basis of us being able to link in and lead on at place with that methodology as well.
Thank you. And Councillor Horgan, I believe you had a follow-up.
Would you like me to ask the second question again? I'll do that. What specific data sharing agreements and technical systems are or will be in place to enable real-time information? Because as we know, real-time information is absolutely vital. That flow across primary care, community, mental health and local authorities.
Yeah, absolutely. So there's a lot of data sharing agreements in currently for real-time data sharing. There is a national discussion currently between government and our general practice leads around data sharing and third-party utilisation. That, for me, is a separate conversation from the conversation that we have here about what is meaningful and real-time. We have commissioning data sets that we are just engaging with general practice and our providers on about constructing new data sharing agreements to enable whole system information to be analysed and to support our population health analysis. And we work with the population health team, public health team, to get that evaluation of our population's needs done in one place. And there are data sharing agreements that are required for that. When we come back to real-time data, the connection between our providers is infrastructure derived, and currently there is not an infrastructure that goes over all of our providers. And we've talked about that here before around electronic patient records and why have we not got electronic patient records across the whole of our system. You can't answer the data sharing agreement on that one until you've got the infrastructure. So what I'm clear on is that we can get real-time data moving around neighbourhoods with the support of our information governance teams to enable that to be fit for practice. It's not going to be a perfectly slick solution. If we were on the government's list for electronic patient records in the whole of our patch, we would be investing time and energy in getting the right data sharing agreements to support that. I do want to put out the fact that there has been some discussion at this group previously around the federated data platform. The data connection that I'm talking about for commissioning use and frontline utilisation of how we identify the people in our population that would be best served by the neighbourhood working is nothing to do with the federated data platform. It's a primary care centric system that has been developed in Hertfordshire that we have seen the benefit of, that we will be sharing across the peach. And it's hosted by an organisation called Oracle. It's nothing to do with Palantir or anybody like that. So I just want to put that out there before anybody feels that we're going down that route. It is not that. And if I'm very honest, the federated data platform does not share primary care data at this point in time. And for neighbourhoods to work, we absolutely need that information, because to get primary care to be sustainable, we need to understand the utilisation of the highest need groups and how we can best serve them to enable them to to have a better experience and have to use less services in the system. So I hope that answers your question, because there absolutely are lots, and we always have a data sharing agreement for any data that we share for a particular purpose. But it is something quite different to have we got real-time record sharing, which I know is a debate that we need to continue to have.
Thank you. Could I just press you on that a little bit more? Because from my own understanding, so you've mentioned that primary care providers are not sharing patient data currently with the wider infrastructure at the ICB. Is that correct?
That's not
Okay.
the implication. So the federated data platform is a national system, and it focused on hospital data sources initially, community providers, those sorts of things. It's got a program to bring primary care data into it, but that isn't fast enough for what we need to do to enable neighbourhood working. So we have invested in a system that pulls that data together that will support our neighbourhood teams to work and enable us to make population level best interest decisions, essentially.
And how close to being successful is that project with bringing all of that data together? Because obviously it sounds like it's quite core to the central idea of this.
It is already live in Hertfordshire and West Essex, and we've taken the learning from there, and the contracts have been signed, and we start the rollout on the 1st of August for the rest of Central East. So that includes Cambridge and Peterborough.
Thank you. I'd personally be grateful if you'd be able to write back to us as well and explain post-August implementation, how that has gone, so that we can assess that for ourselves.
Absolutely. Very, very, very happy to do that, because I think this will be the jewel in our operational crown. So if I've analysed the difference that it's made in Hertfordshire and West Essex and have worked alongside it in previous roles. It fundamentally changes the commission of general practice and enables the visibility of neighbourhood team working, and also very, very importantly, enables us to analyse post intervention of that team, what the benefit to that individual really has been. So are they going to less outpatient appointments? Have they got more joined up care? Ultimately, have they got less people going across their threshold, duplicating the care that they've got? We can see all of the services that are supporting our complex cases in one place. That's not been delivered elsewhere.
Thank you. Councillor Boulat.
Thank you, Chair. I want to ask a bit about the local priorities and how they aligned with the national priorities and the 10-year plan for the NHS. So obviously in the report, we see the three main local priorities: improving access, making it financially sustainable, more productive, and this focus around people remaining, staying in work and staying economically active. On the 10-year plan, there's a strong focus on hospital to community, going to digital, and of course on prevention as well. So the first question, before I ask a follow-up on prevention, is how would the ICB achieve both sets of priorities, both our local ones and national ones, and why are they different? Why do you feel they're different, a bit different, rather than thinking, okay, we'll just focus on the three main government ones?
Yeah, it's a really good point. I think the way to describe it is they are the priorities that will ensure. So our local ones are the ones that will ensure we are financially stable and we have better citizen experience, and that we enable a workforce to be generated for the NHS for the future. So it's really important that we have a pipeline of active citizens that feel that they want to work in the NHS and social care for the future. And keeping people in work, that huge influence of people that experience care become our workforce for the future. So there's a little bit of self-serving in that third one that says not just about keeping people economically active reduces their healthcare needs, but it also generates us a workforce. So they are real needs for us to enable the NHS to be here long term. The mode and the method by which we do it are absolutely those three priorities that nationally have been defined. So shifting from acute to community, that's through our neighbourhood teams, from primary care, prevention to, oh God, I've forgotten them. I used to be able to quote them off. Now I've got a different set of priorities. I can't remember them all. So moving into more the prevention space is absolutely our care model, where we consider prevention in every angle that we work, and how we work together with local authorities and communities to get prevention actively in everything that we do is absolutely key. And moving from analog to digital. So that analog to digital is absolutely about how we will engage the population in using technology to support their self-care, whether that be for musculoskeletal or how they access services for the future. There are many models across Europe that have used AI triage, and we are naturally sceptical in this country. So the diligence that we will need to employ to get that right is absolutely part of the process. But there are national programs that we're working with around digital enablement, for whether we're using the NHS app to do that. And we're one of the test sites for the NHS app to do novel work for the future. I think it's really important that you all know that we're leading the development of those sorts of things with central government, influencing so that we get citizens' experience into that from real life experience, and our general practitioners, clinicians into that as well. And I speak to general practice day in, day out, and they say if you can just drop the demand coming into us, we will be able to do different things. And that digital piece is one of the very strong principles by which the ICB will be working. So it's not that they're different, they sit alongside everything that we do, and we have to consider that shift from acute to community, analog to digital, and prevention as our key strategy.
Thank you. That's very helpful context. If I can follow up on prevention,
Yeah.
could you please tell the committee more about what additional investment is actually going into prevention, and maybe a broader question around how can we actually demonstrate success, or what are we measuring beyond this longer term ambition? Because with prevention, it's sometimes very difficult to measure or to see in the short term what impact those investments have. So is there a way to actually demonstrate this prevention approach actually works beyond the longer term ambition to move from the sickness approach towards prevention?
Yeah. So I think I'll use one of the examples within the strategy around cancer. So actually, we know that if we can detect cancers earlier, that we can have better outcomes for those that are affected by it, and also reduce the spend. It's a win-win situation. So our prevention is very much about secondary prevention and ensuring that we've got a system that talks about healthy living in combination together. So Sally sits to your right. We are not trying to be directors of public health in doing this. We absolutely know that the primary prevention agenda sits hand in glove with our public health colleagues, but it's our job to make that land and ensure that in our populations where take up of screening and prevention interventions is lower, that we have integrated neighbourhood teams that start the conversation, that have trusted conversations. So I think we know where our responsibilities sit. So it's not duplicative, but we have a prevention lens through every one of the services that we're looking at. So I don't think we've always considered it in that way. We've said, how do we manage the crisis? How do we manage the crisis? But we're actually taking a business model now that says, consider the prevention. Where can you start the prevention earlier? So for colorectal cancers, can we open up greater screening? Can we get people in earlier to enable us to detect cancers at stage 1 or stage 2, where we know the outcomes are better? So it's that kind of methodology going through everything that we do to ensure that we get best outcomes for our population.
Thank you.
Where we go now?
That is reassuring, actually, on secondary prevention. Now, I'm keen to move on to finances in a second, because I'm certain there are questions about that. But just to press you on what Councillor Bulak was asking about, I interpreted the question more about primary prevention, stopping illnesses or injuries ahead of time, as opposed to screening and secondary prevention. So would you be able to answer the question in relation to that?
Yeah, so in an organisation of our size, we'd be remiss if we weren't looking at the highest level of technology to help us identify those at greatest risk of things like cardiovascular disease. So we do have programs that are saying, how can we look at the genetics? How can we look at predictive tools to be able to intervene? But I'm really clear that is about a population that we've got information on. We hold that key that actually, if you start to look at the population, where do we take the opportunity to identify through health services those that would be at greater risk of developing illness? Where we've got the wider determinants of health that are determining people's health burden, so the lived environment, the access to economic stability, isolation, all of those sorts of things, that can't be a health prevention agenda on its own. So that is absolutely where we work with public health to reduce those kind of the incidence of those life-limiting health choices. So whether that be smoking, obesity, and obesity, alcohol, drug taking, those sorts of things. Sally's giving me the prompts over there. But that is in partnership with our colleagues and is not solely a health responsibility. So we know that those things have to be done in together. But where there's an opportunity to make every contact count within our services, because somebody has presented and said, I don't feel so well, or they clearly need support with a healthy weight. And I use the term healthy weight very specifically because it is about healthy weight. We lock into that, but we have to know how we're working together. And I think, again, with the Health and Wellbeing Board, with the strategies that we've developed, we've clearly set that out. But you would expect health to commission the right intervention for those that are experiencing the early stages of these care and do that secondary prevention really, really well, so the complications are mitigated. But it's not to say that we aren't saying, is there a genetic solution to identifying our population better and putting the best medication in to reduce incidence? So, you know, the approach that statins had for the reduction of cardiovascular disease, if we initiated and reduced blood pressure in the population as a whole, we would have an impact. But that is the sort of prevention that we hold the key to influence.
Thank you very much. Councillor Malinowski, and then we will move on to finances after that.
Thank you, Chair. So I was just really interested listening to your response to Councillor Boulat, and particularly what you said about analog and digital. And that made me think, oh, I've got a problem getting into my NHS app. So I've just tried to log in, and I've got some error message with a reference, unable to get in because of an issue with my NHS number. If I'm struggling with this technology, what chance do vulnerable residents have? And I think what I'm really trying to press you on here is not necessarily why can't I get into the NHS app, but the point that if there is a significant piece of work moving people to digital because it helps so much, what work is going into making sure that people can access help with technological issues when they come up to obstacles with those systems that maybe they haven't expected before, bearing in mind that a lot of the people who will have the most use of these services will be more vulnerable people potentially? And does that have a cost as well? Thank you.
Yeah, it's a really valid point, and I just want to be explicit that it's an 80-20 rule again. So if you speak to anybody below the age of 35, they do not want to speak to anybody on the telephone, let alone a healthcare professional. You know, we are moving into a very different way of working, and we have to recognise that 25% of our population are under the age of 18. They expect our services to be accessible in a digital platform. We recognise that learning from local authority experience, actually people engage with their rent reimbursement, you know, all of the benefits, those sorts of things, in times generally when offices would have traditionally been closed. We see that, you know, people are taking the opportunity when it fits with their life to engage with their health. That does not mean that 100% of our population will need to access health through digital platforms. If we get the majority of people that are comfortable to use digital platforms, that gives a better experience for those that need to continue to pick up the telephone and use traditional methods to get access to services. And that is the means by which we always consider digital transformation, because there are some people that will not be able to engage with it. However, being the carer of a 77-year-old individual with a neurological disorder, he is better at using the NHS app than I am. I'm very embarrassed to say so. So we mustn't underestimate what that gives people as an opportunity if they're disabled and struggle with, you know, my father has a speech problem. Actually using everything through an app makes the world more accessible. So there are two sides to every conversation on that. Where I have rolled out greater digital engagement before, I've absolutely done it with a local authority. So the population that we're talking about that have the highest level of need, we all know them and we're all intervening with them. Actually, if we just divided our digital support services across all of that population and spent time saying, how can we get you on the app? Because you know what, it might help you manage your rent arrears as well as your ordering of your prescriptions, we start to have a very, very different conversation. There is obviously a cost associated with it, but I've seen the investment in our voluntary sector to support people to become more digitally active as the most sustainable solution to that. And usually right in the heart of the community. I'm not going to say library because it's often contentious, but you know, we do see that people will access through coffee groups, all sorts of things, digital support. And if we support into that as a collective, you know what, we'll get much better take up.
Thank you. Councillor Dr. Noels, did you want to come in here as well?
Thank you. Thanks for that. Now we are celebrating the first anniversary of government's 10-year plan. How many neighbourhood care centres actually exist in Cambridgeshire at the moment? And given that more and more responsibilities are being shifted from secondary to primary care, you mentioned the 80-20 formula, presumably not only administratively, but also financially. No doubt we will discuss this later on under the ICB finances. But briefly, administratively and financially, would it be appropriate to apply the old clothes to a new and growing body? Would it be effective? The second question is about making people economically active. That is again one of the major government's flagship initiatives, whereby it is aimed to achieve 80% economically active population or employment rate, if you like. What delivery model do you have? How is it going to operate? And the 5 priority areas you've mentioned, I think are absolutely right and well thought out, and one hopes they work in practice as well as in theory. But what things would you do differently from what you do now? Would you be shifting extra resources to this side? And if so, would it be expense of some other existing services? I say that because at the moment, you know, you have huge waiting lists in mental health, particularly of young people, in cancer treatment, although that has been expedited considerably, and the responsible authorities have to be commended on that. But in other services such as rheumatology, again, you know, you may have over a year or possibly 2 years to get an appointment, and these are the sort of target group who would be the candidates for getting back to work program. And thirdly, I hear what you say about digital data. Again, I think this would be useful. And yes, I do understand, and I'm going to separate it from what you alluded to, Palantir. And by the way, for your information, we are hoping that they will no longer be in the game because their values do not coincide with the values of this country, totally not. They were CIA backed and they have some other histories, but I'm not going to go on into that. What you said was about the quality of service. You will be using, quote, unquote, citizen voice. Given that Health Watch is probably likely to be abolished, and the mandate for monitoring the citizen voice has been given to the ICBs, I think, or to the commissioning part of the NHS. How do you plan to deal with that? Thank you.
You'll definitely have to remind me of them all as we go through as questions. So I was listening very intently, but I've probably forgotten them. I came up here without my pad, which is because I came in late. I always have my pad with Scrutiny, so apologies for that.
No,
So
that's fine, Chair. I'll be happy to repeat.
Okay, but so I think the first question was around the delivery model operation, how the 5 priority areas are being prioritised.
It was neighbourhood health centres, wasn't it? Did we go neighbourhood health
Yes,
centres?
it was.
Yeah. So we're still in the process with neighbourhood health centres. I want to be very, very honest with the committee that the money committed to it nationally does not build a neighbourhood health centre on every corner. It sounds crass, but 50 million does not give you an infrastructure across every neighbourhood. So 50 million is the budget nationally to support the rollout.
Are we saying, Chair, that we don't have single neighbourhood centre in Cambridgeshire at the moment?
No, we're not saying that. We've identified 56 across Central East, and we're going through the process of identifying which would be the most appropriate centres to go through the process. And that is a process that we're going with regional colleagues, because NHS England also have a role in that decision making. We will absolutely have neighbourhood health centres, and unless we do, we won't have the shift to neighbourhood delivery, because we know that we're resource constrained within community and primary care sources. But between the public estate, we have a huge amount of estate that we can use that is close to our population. And we talk about it regularly as officers on both sides of health and social care, that the infrastructure must be brought together to give family centres alongside mental health hubs, and actually not having multiple of these offers in one geography. Having a complete offer is very, very important. So I would urge us to do that piece of work together that says,
particularly, Chair, forgive me,
map it all.
We don't have any neighbourhood health centre at the moment. That's all I needed to know. We don't have any time scale.
But they're in the process. They are in the process. So we are working through that. We're doing a stock take of all of the estate that we have got and the planning developments that are going on around. So this will be within this financial year that we will have to make our decision.
May I just intervene for a second there then? Could I make a suggestion then that you write back to us in December and you let us know how that prioritisation process has gone and which ones you are prioritising? Because I think that's an important question.
The chief executives of all the local authorities have been written to say this is the process that we're going through. So you can absolutely have a copy of that as well.
Thank you. I think that would be good for this committee to see.
Yeah, thank you for that. We really do. And my second question, I will repeat it to you, is about the economically inactive people, how to bring them into employment. And I absolutely agree with you that it would be beneficial in the long run. It would be very cost effective because it would prevent a lot of medical problems, particularly the mental issues such as anxiety, emotional issues, depression, so on. So that's absolutely right. But what I was asking was that how is this model going to operate? Because the government's aim of getting to 80% employment rate, and if you're going to persist with the 80-20 formula.
Can I come in on the answer? Because I've got the answer for you.
Thank you.
So we are the national exemplar for the Workwell model, which has been adopted across the whole of the country now. We were one of the pilot sites. We've managed, because we've linked directly with primary care and the care coordination, the conversations that happen in the voluntary sector with these individuals when they pop up anywhere in the system can get a Workwell offer. And that is a complete offer that supports people to pre-employment, post-employment, to find other meaningful work, has personal budgets associated with it. So what we have found is that a lot of our population that experience neurodiversity are struggling to hold down meaningful employment. And actually, we've given coaching, we've given all sorts of resources out to those groups that have found it difficult to work. And we have it. And I'm very happy to get the group that have led that, both my team and local authority teams, as well as voluntary sector colleagues, to come here and present that work, because it is absolutely now being rolled out across the country. And it is an asset-based approach. So it's looking at the individual strengths, giving coaching and support, whether that be because of a physical or mental health presentation, or a socio determinant that is reducing access to work. So that could, what we found is travel has been preclusive to people holding down work. So working with the mayoral authorities around tiger passes so that our young people can actually access college and education. So we feel really confident that we've got a delivery model. Absolutely got a delivery model, and it's one that really links into neighbourhoods, because it's been developed at a PCN level, and it's been developed with our voluntary sector, local authority partners at that neighbourhood space.
Chair, thank you. If we are to accept that offer, I will not ask any more questions on this particular topic. But final question is about the quality of care. And you said that this will be monitored through citizen voice. I would like you to elaborate on that, please, because you're abolishing the Health Watch.
So that was a national decision around Health Watch, and very conscious that we've got our Health Watch chief executive here. And I think at the moment, and correct me if I'm wrong, Jess, but that hasn't had a final decree as to what is going to happen. However, we see that the responsibility to engage with our population, work with the Health Watch infrastructure, is critical to our future delivery. And we will be working with all of our Health Watches to make sure that there's a safe way of continuing that work. We are awaiting national guidance on that still. So, but that doesn't mean that we will not engage with Health Watch while they're still here, and use the resource. Jess and I have regular dialogue, but we have a responsibility to engage as a statutory organisation on every change and development that we have. Now, we should do that in the best possible way, because we know investment in that, not in a tokenistic way, but a really open and transparent way, actually delivers better outcomes and outputs in service design for the future. And we must be held to account to do that in a really rigorous and robust way. And I feel confident that we've got the infrastructure to do that now.
Thank you. I appreciate the importance of this.
Yeah.
It is absolutely essential we do that. I was looking more for, if you have, given that this has been going on for nearly 2 years now, it's been in the pipeline that Health Watch will be abolished. Do you have any specific ideas, plans, pathways for substituting the function of Health Watch? Thank you.
So I'll go back to the fact that as an ICB, we have a responsibility to engage, and the total quality management approach that we've got means that we will absolutely recruit citizens with lived experience and clinicians with system experience to design and be in the center of the design of everything that we do for the future. So that is a commitment that if you speak to any one of the executives of the ICB, we have made. So we have ensured that that is part of our design process.
Thank you, Pam. I'd like to move on to the finances now. There are a couple of priorities in that area that I'd like to focus on. And Councillor Kane had one particular question that I think.
Sorry, I just want to focus on something. I've been here getting really riled up by something you said earlier. And I think given that we're health scrutiny, I think it's really important that we do raise it. You talked about the priorities, and you talked about lifestyle conditions, and you talked about drugs, alcohol, smoking, and then you put obesity in there. And I'm really concerned that the representative of the ICB portrays obesity as a lifestyle condition when, like, the World Health Organization, the British Medical Organization, refer to it as a complex chronic disease. And my concern is we have the biggest fight with obesity, something I've battled with since I was born, and something that at the council it's an area we're not doing very well at. And I think my concern is that when we portray it as a lifestyle condition, the stigma effectively puts a barrier towards compassionate sort of treatment. And I just think maybe that wording's a little bit clunky, and I just wanted a bit of reassurance that that wasn't how that ICB was going to sort of deal with the issue of obesity, which is such a serious issue. Sorry, Chair.
I'm really sorry that that's offended you, and I'm really sorry for the clunky nature of that. I'm really committed as a clinician, having worked for many years in the NHS, and know exactly the predicament that you've talked about, and I do not want to reinforce stigma at all. We have to recognise that we have obesogenic environments, and that changes the way that people make decisions. There is a level of chronicity, but we also have to take responsibility as statutory organisations to mitigate that obesogenic environment and put priority on physical activity, put priority in our schools in keeping green space, ensure that there is not a discrimination when our colleagues with a higher or lower weight come into our services, because actually the discrimination is on both ends, which is why I very consciously used healthy weight, because actually we need to move from that. So I'm sorry that it felt like a discriminative comment. It really wasn't. But I think we have to recognise, working with our public health colleagues, that we can impact that. They are modifiable in many cases, and modifiable we should take the opportunity because of the consequence. I'm a physiotherapist by profession, so the consequence in later years is significant, and it should be all of our responsibility to do that without discrimination.
Thank you. I'd just like to bring in Sally, please.
Thank you. I won't take up much time. I just wanted to give a bit of reassurance as well. I think the phrase lifestyle is kind of old-fashioned, and but it still gets used sort of shorthand for obesity issues. But I just wanted to provide a bit of reassurance that from working with Pam has got some training in public health as well, and gets all of that. But I think sometimes we just revert to the shorthand of saying lifestyle. But absolutely, can reassure you that Pam gets the kind of complex nature of obesity from the conversations I've had with her, and as a system, it is understood that it is much more around the environment rather than a behaviour choice.
Thank you. I just wanted, as I said, it was sitting riling me up, and I kind of figured it was a miss kind of just thing. Yeah. That I just wanted some.
And I will very willingly take any of that challenge in the way that it's proposed. So thank you for having the honesty to bring that out. I really welcome it.
I'll now ask my finance question.
Is it finance now?
Yeah, it's finance.
So I'd like to do more on obesity, if that's all right.
So I sit as an appointed governor on the CPFT.
Yeah.
And you've talked a little bit about this, but I'm just interested to sort of just really understand more about how you plan to maintain and strengthen relationships with partners while flatlining average NHS spend per resident.
Yeah. So what we need to recognise, and when we're able to show you some of this data, and we'll anonymise it, obviously, but we can bring here some of the examples of how we're seeing our population being asked to go to multiple points and have multiple interventions in their care, and it's not joined up, that there is a cost associated with that. So we have, in this country, we have a higher utilisation of services because we work in a super specialist way. So we actually, if you're experiencing cardiovascular disease, diabetes, early stages of chronic kidney illness, and you happen to have a neurological condition as well, you know what, you're going to be going in and out of our services constantly. And the reality is there is a cost associated with that. But we've designed that. We have absolutely designed that. What our role is to do is to reduce the utilisation of services and improve the outcomes. But people think that that's unachievable. But actually, if you think about coordinated consultant care, and actually looking at a person in a whole and having a single clinic appointment to review all of those things, or perhaps actually saying what is the single most important condition for us to treat in that individual, because it's complicating everything else. You know what, we'd start to reduce the spend in our system very, very quickly. Now, we haven't had the bravery to do that before because we've had a very traditional setup of services, and it is going to be disruptive. But when you talk to the population, if you've got chronic illness, actually, it's a full-time job going in and out of hospitals and community services just to keep up with your checks. We should actually design a more person-centric system. So we're having to have flat cash because that's the budget that we've been given. But actually, there is an opportunity to reduce that utilisation within our system and produce better outcomes. But it's going to take us all holding our nerve and going on that journey together. But I think we've been clear that that is our expectation of providers, and the providers want to work like that. And I can tell you really clearly that our retention of our workforce and some of the very well-trained experts, actually, if they don't get the opportunity to work in a modern way, they won't want to operate in this area because they want a more holistic way of working, because actually it delivers a better outcome for the clinician as well as the individual. So that's a very important methodology underneath our utilisation. And we can see now through these data platforms how often our population are having to go and access services. It's exhausting. It's absolutely exhausting, firstly.
Thank you. Councillor Horgan.
Yeah, thank you, Chair. I think the message of flatlining average NHS spend per resident might be concerning, that it might mean reducing access or creating unintended rationing effects. So what reassurance can you give us that that won't be the case, please?
I come back to the philosophy that is we're over utilising services at the moment. We've designed that and we expect the population to come and use those services when actually they're not designed around them. So the coordination of care for an individual will mean that we use less services but give a better outcome. And that is not something that we've developed here. That's very well understood through European systems, etc. That actually, unless we do this, we're going to continue to oversee poorer outcomes with high spend. We're one of the highest cost systems in the world, but we can do better on the outcomes, and that is through the join up of the care, the coordination of the care. So I believe we'll be able to take out the utilisation levels and drop them down to enable us to be a sustainable system. Now we see that very, very clearly with our frail population, and I'm very consciously not using frail elderly population because we know in our most deprived populations that frailty can start mid-40s. So actually we're taking an all-age approach to that. But you can look at end-of-life services in the same way, that unless you coordinate the care, you deliver poorer outcomes with higher spend. And that has to be the rigorous financial evaluation that we do on all of our services to enable us to live within the cost envelope that we've got. And actually, most of the providers are really signed up to that.
Thank you. I've got Councillor Howard, then Councillor Malinowski, and then I'll move on to patient care. Councillor Howard.
I think the ICB are lucky to have you. You're doing a brilliant job.
Even though I was half an hour late, I'm really glad.
Tell I'm just about to be horrible to you. What I would say in response to your last answer, we may be spending more on health, but that's because many other countries have a much more significant private element to their healthcare and private health insurance element. And the international comparisons, I'm sure you know, show that we're one of the most efficient health services in the world, what we get out of it. So I think it's important to say that to you, having heard what you said. But my actual question about finance is this. Have you given up on systems working? There's one reference to systems thinking in your strategy, but you know that we've spent the last 4 or 5 years talking about trying to have a systems approach. And yet I heard last week that you've just got lawyers to go through all your current spending, worked out that the doctors that do assessments for deprivation of liberty should be a local authority scheme, so just gave notice and said you wouldn't do it. And your chief executive, on many occasions, I've heard say it's whack-a-mole. If you bring the hammer down here and it just comes up somewhere else, it just disadvantages the system's partner, and in the end is fobbing off the need and saying it's not our job, governor. And so put it on your plate. And of course, that type of thinking and behaviour simply says to local authorities like this one, we'll do the same. We'll say anything, we'll find anything we can that we can fob off onto you, and we'll just do it without discussion, without having a cooperative or partnership approach at all. So it really dismayed me, particularly after the whole saga of the LDP, which none of us were covered in glory over. Let's be honest about that. You know, this is an example of exactly the same behaviour. And I hope that you will say something that will give me some hope that you might have a more cooperative partnership approach with local authorities than that example shows.
Okay. So the example that you've given, I am drawing from my sort of recesses of a different team, but is a Section 75 agreement, I would assume, for the deprivation of liberties assessment. I have, in fact, systems thinking theory is absolutely the work that I did on obesity in Essex, across the whole Greater Essex. So I believe in systems thinking theory, and actually, if we don't do that, we won't get the right answer for our population, because there is more to the 80% of influence on someone's well-being is not just held in health. So we can't do this in isolation, and we won't get the right answer. Do I have the specific answer for you? Notice given on deprivation of liberties? No, but I will go back and I feel that the relationship between myself and Cambridge County Council is primacy. I feel I hold accountability for that relationship, and Patrick and Sally will attest to the fact that I have intervened where there is something that is going to damage that relationship, and I'm trying to move them forward. I have worked with local authorities for 20 years, and we don't want whack-a-mole, because all it does is impact the citizen as opposed to anybody's budget lines. So let me go back and look at that, and I'll come back to you.
Obviously, I can ask no more, but obviously you're representing the ICB here, not yourself. And it is an example where I believe the relationship with the local authority is damaged. And if the ICB had simply come and said, look, this is a problem, we shouldn't really be funding this, how can we deal with it, how can we transition away from it, that would have been fine, because legally I accept, if all the advice is that you don't have to pay for it, it's how you did it which damages the relationship.
And I can give you a counter example to that, where we've worked really hard on CHC assessments and mental health assessments to make sure that we've stepped into that in a partnership way, and it's been really restorative to the relationships. So, and I've overseen that. So the relationship with the local authority is absolutely, it's so important for us to do that. So I'm sorry that it's done that, we've had that impact, but please let me go away and have a look at it. There's no one else responsible for Cambridge and Peterborough but me. So, I have to take responsibility, and I will.
Thank you. Councillor Malinowski.
Thank you, Chair. So 10.2, your top three system outcomes are increase patient reporting satisfaction with access to primary care, obviously. Decrease the average number of days residents spend on waiting lists. And flatline average NHS spend per resident, as Councillor Horgan says. I just want to understand how 2 and 3 can work together. If you're decreasing the average number of days people are spending on waiting lists, surely that is going to require more spend per resident to help people get off the list and get into the services they need. If you could just talk the committee through how that is intended to work, that would be very grateful. Thank you.
Yeah. Okay. So this is the twin track of life, isn't it? So you've always got care in your hopper that you need to deal with, on waiting lists. We've seen a material impact on waiting list times because of weekends, evenings, catch up that has been done. So that is not sustainable in the current state. So actually what we've got to do is have a system that intervenes earlier, that reduces the demand for people to sit on waiting lists. And I think that's what we've talked about the whole way through the session today, is actually we know that if we create healthier lives and we mitigate the cardiovascular disease burden or the orthopedic burden because people are physically active for longer, and we've worked together to make physically active environments, active travel to be the first choice. I mean, you're doing pretty well in central Cambridgeshire on that, but the broader areas don't, and we need to find some equity in that actually we will start to reduce the demand. And it's got to be right time. It's got to be earlier intervention. Actually, what we find is people waiting on waiting lists consume so much resource because they don't know where they are on the waiting list. We've got waiting well interventions. Actually, we need to, there was a call to stratify your waiting lists by those that are experiencing higher rates of inequality. They are the same people that we would be picking up in our integrated neighbourhood teams and offering different solutions to. And as the time goes round, that we, with the next set of referrals, we'll be doing earlier intervention. So they do marry, but not in the same time frame. They're iterative, so you have to do one to get the benefit of the other. But unless we look to the long term, we're never going to get ourselves out of this consumption journey at the moment. So we have to treat it now, and we have to have what's the plan for the future. So they are hand in glove. We should have an aspiration to reduce the spend because we are intervening earlier and giving the best advice. And that's not necessarily just from health. That is from that collective whole person view.
Thank you very much. So I'm conscious we've got I'm going to allocate another 10 minutes to the discussion on this item. And I'd like to now focus on patient care, appreciating, of course, a lot of the questions we've had so far have indirectly worked on patient care. But specifically, we had some questions. Any councillors like to kick us off on this particular section around patient care? Councillor Noise.
Thank you. Yeah, this is slightly different, and it's an easy one.
Good.
In allocation of resources, now I'm sure you are quite aware of health inequalities, and there are some very substantial health inequalities. Whether for example, you take life expectancy, mortality rate, so on. Between North Cambridgeshire, in particular North East Cambridgeshire and South Cambridgeshire. For example, the GP to patient ratio in Cambridge is 1 to about 2,000. That in Fenland is 1 to 2,500, as the committee were informed by your colleague, Dr. Booth. Now, how are you going to allocate the resources? Will there be any attention paid to the actual health needs, and will there be a desire for levelling up of the health status of various areas? Thank you.
Okay, so this is always a tricky one, isn't it? And it comes back to our public health training again around universal proportionalism. So actually what we need to do, and what again our population health statistics tell us, is that those experiencing higher level of inequalities are having the worst outcomes. And actually it's a 14-year life expectancy gap across Cambridge and Peterborough. And I know Peterborough is not this authority's responsibility, but it really heightens in a small mileage the difference. So we are overseeing the highest inequality across that 3.5 million population. So it's sobering, isn't it? It's really sobering. What I also find, having worked with deprived communities in other parts of the east of England, the highest levels of innovation tend to be in those highest levels of deprivation. Now, because it's absolutely need. Working on a neighbourhood-based approach enables us to put the focus and the resources into the populations that will benefit the most. And we have to balance the system, be bold about that, because the consumption of resources associated to the higher levels of deprivation are really clear, they're tangible, they're there in our population health data. So we will have to work in that way. But what we will have is, for areas with lower levels of inequality, we will have facilitative support to enable the best models of care to be developed. Now, when it comes to retention and recruitment of GPs, we can go into a national debate around, is there enough reimbursement to have the level of GPs that you need for those populations? We've done a levelling up initiative here that goes outside of the Cahill formula to enable there to be more resources associated with those populations that have higher level of need. And the ICB has not stepped away from that. We await a rebasing of the Cahill formula nationally. I understand it was on Wes Streeting's desk for sign-off at the point he left his role. So we are asking the question of when is that going to come to bear, because that will force us to do even more than what we've currently done. But we have done something novel to support practices. I accept it's not enough, but what it is a commitment to that direction of high level of need, high level of reimbursement. But actually, what we need to do is get around those populations and give resources from our collective assets between us to those populations to work in this joined up way, because we know that reduces the utilisation. So it's being brave and saying, yes, we will commit our resources to that integrated working, knowing that we will become more sustainable as we go down the route. So there are two tracks to that. There's a purely financial route that we have committed, and also creating a different way of working in those high levels of need that don't burn out our workforce, that help us retain our workforce and enable us to grow our own. And growing our own GPs from our communities that understand the communities is absolutely the strategy we should be working for. But it's not just a GP model now, is it? It's very much, we've got high levels of nursing roles that are now able to carry a different caseload through the additional roles reimbursement model. We've got my own profession, first contact practitioners, giving musculoskeletal advice very early without a waiting list ever needing to be sat on. So that clinical workforce, as you well know, is very, very different now. And we can build on that. We can absolutely build on that.
Put it simply, there will be extra resources to address the inequalities. Yes or no will do. Thank you.
We have to, because otherwise we will continue to preside over the health inequality gap that we see now. So we have to.
Okay, thank you. I'd like to bring in Councillor Malinowski and then Councillor Horgan, if you could. I'm particularly interested in your question you raised about AI, if you might be interested in asking that. But
yeah,
we'll take Councillor Malinowski first, please.
Thank you, Chair. I was just going to stay on waiting lists a little bit, and thinking about your answer before about obviously the long term, sort of looking to the horizon on that. I'm concerned about average wait times for the services that experience the highest demand, and in particular, it's mentioned throughout here, and we've talked about it a little bit earlier, that the acute care pathway for mental illness. And how you would plan to reduce those wait times, and if that ties into what you've just been speaking about.
This is a really significant priority for us. I don't think we've necessarily focused on crisis mental health care. We've done a lot. This is the conundrum between prevention and crisis always. And we've taken a conscious decision to say, actually, we now need to really focus on crisis care because that's the highest risk area. It's the area that leads to highest levels of suicide. Actually, we need to do both. Always we need to do both, but there is a structural redesign that needs to be given on mental health crisis, and we have a program of work, and if you would like to be involved in that, absolutely we can enable that to happen for mental health crisis through that business structure model that I've talked about and that life cycle care model from prevention to crisis. The one on crisis is absolutely about mental health crisis. So I think we've been very focused on physical health waiting lists. It's a political narrative. I think waiting for mental health support doesn't get talked about enough, and we've made that conscious decision that we're going to do that.
Thank you. Now, before I draw this debate to a close, Councillor Horgan.
Yeah, thank you, Chair. You'll be pleased to hear that I won't be asking the 5 questions I had in this section.
Really?
In the interest of time.
Just fired up for that.
Well, actually, 2 of which you've already answered.
Oh, good.
Yeah,
You
and
can send me them
Chair
afterwards if you
referred to about the AI self-care technology. If I remember what I think you said was using the 80-20 rule. The more you get doing digital, the more resource there is freed up that are going to need the support, perhaps on a telephone or something like that. So I think that's answered that question. So the one that I do want to ask still, and this is about early stage cancer diagnosis. And my question basically is, how will the ICB increase early stage cancer diagnosis, and specifically what investment is being made to expand screening capacity and reduce variation?
Okay, so I know this was talked about, and we have fed back that we don't commission screening. So that's NHS England's responsibility. So, but what we are doing under our resources is, again, if you look in that care model, the first prevention initiative that we've gone after is colorectal cancer for greater uptake of screening. So our responsibility in that space is to ensure we have really good quality uptake of cancer screening, not necessarily the commission as whole, because that is NHS England's responsibility, but we work with them. I think we have seen some incredible models, and we've got a program. In fact, they met this morning around cancer, early identification of cancer. We are using colorectal first. So one of the things that we've got to be really clear on is we can't do everything at the same time and do it well. So we absolutely have to road test this way of working with a single example to start with, get it nailed, and then go on to the next challenge. So colorectal cancer was decided because of the ability to modify if you get in early, the lower cost interventions that actually extend people's quality of life. So we are attributing our resources to colorectal cancer firstly. And again, very welcome for you to be involved in that if that is something that you want to be involved in, to actually start to prove the case that if we intervene early, we do free up resources so that we can do more prevention, and that we could then start to say perhaps we are going to supplement the screening budget so that we move outside of our own lane and say actually we know that the economic and the outcome benefit is really clear, but we've got to prove that. We've absolutely got to prove that case. I think it will prove that case, but trusted relationships with our community to encourage screening is about the interaction you have with everybody. That means you feel worthy of doing your bowel screening test at the age of 50. Trust me, I've just had mine come through the door. I'm motivated, I know the benefits, but actually if I'm experiencing hardship, domestic violence, you know what, that's probably going to drop down the list of priorities. So encouraging people to feel safe enough to do that. We know that women experiencing domestic violence don't go for their cervical screening. Like, it's a group that rarely put themselves at the front of that process. So there's lots of confounding factors that mean that early identification and prevention lands or doesn't land. And it's all of our responsibilities to make sure that we have safe environments that people can come and say, you know, I now feel ready to do that. Or a conversation that then says, have you thought about having your screening tests? So it's not always about budget in these cases. It's sometimes about the equity in which we treat our population, the way we build trust. And building trust is about the type of conversation that you have with people. And if we build teams that are able to have those conversations, that are more embedded in the community, the take-up will start to increase.
Thank you very much. Now, usually I would ask if the committee has any further questions, but we are quite behind on time, so I'm going to draw that debate to a close. Thank you very much for your questions, committee. Again, usually I'd like to summarise the concerns that we've had. However, I'll leave that to Democratic Services. The things I do want to summarise, though, are the answers that we have to come back on. So I think we agree that you'd bring back evidence to the committee of the prioritisation of integrated neighbourhoods and the local primary care and how integrated neighbourhoods are being funded. And right back to the committee on the ongoing joined up data sharing project that will commence from August the 1st. And the process that's ongoing to see which neighbourhood health centres would be most appropriate to go through that process. Yep. So those are the key actions I'd like to make a note of. And
do we want to note work well as well as for a future agenda?
Say that again for me.
The work well team and the return to economic stability interventions that we've done. I mean, if you want to have a briefing outside of the committee, if you want to arrange that, then I'll work with Rishenda to make sure we do that.
Thank you very much.
Yes, thank you very much.
Yeah.
So committee, I propose therefore that we delegate the authority to Democratic Services Officer in consultation with the Chair and Vice Chair to produce a summary of our feedback and recommendations to the relevant parties. Are members happy to agree that unanimously, or does anybody want to move to the vote? Conscious this means only County Council members will be able to vote, but getting lots of reassuring nods, so we'll take that as unanimous. Thank you. Yes, thank you very much, Pam. I appreciate your time today. Now, I'm going to propose that we have a 5-minute break, so if we could come back at 12:12, we'll then start the next debate. Okay, thank you very much, members. So item 6 on our agenda is the North West Anglia NHS Foundation Trust, which we call NWAFT. I hope I'm using that acronym correctly. At the last meeting, the committee heard Councillor Tom Sanderson, the County Councillor's partner governor at NWAFT, and the local member for Hinchinbrook Hospital share his concerns about patient record systems at NWAFT. This concern has also been voiced by the Integrated Care Board representatives during scrutiny of delivery of the NHS 10-year plan in Cambridge last year. The Chief Executive of NWAFT also recommended scrutiny of this item to the committee, and we welcome that proactive approach to the constructive challenge with which this committee can provide. We're joined today by Charlotte Williams, the Deputy Chief Executive of NWAFT. And I don't know your name, sorry, would you like to introduce yourself?
Yes, good morning, everyone. My name's Geraldine Wingfield Hill. I'm the Chief Digital Information Officer, also at NWAFT. Thank you.
Thank you, Geraldine. We're also joined by Councillor Tom Sanderson, and we welcome his input throughout the debate. I'd like to begin by asking Charlotte to introduce her report and provide a brief overview of the services that NWAFT provides in Cambridgeshire. And then I'll follow up with Councillor Sanderson if he wishes to add any further opening comments. So Charlotte, over to you.
Good afternoon, everybody. Thank you very much for having us today. As introduced, I'm Charlotte Williams, Deputy Chief Executive of NWAFT, and I also am the board executive member responsible for digital services, so lead on the work around patient records. I've asked Geraldine to accompany me today because I noted some of the questions that councillors had related to our technical infrastructure, and I felt it would probably be helpful in responding to some of those questions. So thank you for welcoming Geraldine. Before I move on to the report, I was advised it might be helpful, just as you say, to describe a little bit about North West Anglia NHS Foundation Trust. So we are a large hospital trust, foundation trust in the health service. We operate 2 acute sites, one in Hinchinbrook Hospital, and one in Peterborough City Hospital. And we also operate a number of smaller sites, satellite sites, notably Stamford and Rutland Hospital in Stamford, Lincolnshire. And we also operate services from Doddington Hospital in Fenland and work in partnership with Cambridge University Hospitals and King's Lynn to support community services in Wisbech, also in Ely at present. So we have around 1,100 beds or so across our services, with a split of about 1/3 Hinchinbrook to 2/3 Peterborough, with 1 rehabilitation ward in Stamford. And we probably have about 1.6 million patient contacts per year. And we also support and host the North Place, which is an organisational structure that brings together partners across health and social care to progress neighbourhood health, much of which you will have heard about from our ICB colleague. And we have around 7,000 employees within the trust. So in relation to electronic patient records, we were asked to give you a little bit of a history, I think, of how North West Anglia NHS Foundation Trust finds itself in the position that we're in, which is that we're one of a single number of hospital trusts across England that doesn't have a guaranteed route to securing the necessary investment for a comprehensive electronic patient record system within a hospital. There are other organisations in a similar position, particularly across, say, ambulance services, community mental health services. But in relation to hospitals, the vast majority have recently received investment to support modernisation through national programmes, which we've outlined in the paper. To be clear, I do need to make one clarification, unfortunately, to an item of shorthand, I think, that was referred to in our paper. So apologies for that. Under item 2.4 for the minutes, if I could note the point about legal considerations related to procurement. I actually need to say that during the procurement, the information received was reviewed as being insufficient to enable us to compare bids on a like-for-like basis, and therefore we weren't able to complete the procurement. So it wasn't that we sort of were advised by lawyers or anything, just to be clear. We were not able to complete that procurement due to the insufficient information provided. So I think that the story is that we've had a lot of opportunities to put forward our case for investment, working up a number of outline business cases, but we've, I think, fallen foul of the funding cycle at a national level, and we've effectively timed out on the previous cycle of investment, and are now awaiting further information about financial support. To give you an idea of the affordability gap, which we refer to in the paper, this is around £30 million. That's about the affordability gap. And this has recently been re-established following our previous business cases through pre-market engagement. So effectively, we've been working to test the market for suppliers of these sorts of products in order to establish a thorough financial case. Historically, we had agreement for support for that through NHS England, and at the moment we're waiting for that to be confirmed. Of late, we have received support through our Member of Parliament for Hinchinbrook, Ben Abisi-Jekti. He's raised questions in the House of Commons in relation to this. It's particularly acute for us on our Hinchinbrook site because colleagues may be aware that we're part of the new hospital programme for reconstruction of the Hinchinbrook site in a large part, which is due to, demolition's underway, is due to be completed in 2032. And that hospital will require us to have a much more sophisticated level of digital capability. So Ben has been very proactive in trying to make sure that our path to the new hospital is well supported through our digital infrastructure. So since I think we wrote the report, we have received a little more information through NHS England about the digital programmes at national level. And we've also received a letter of support for us from the one of the ministers that they will look favourably into supporting MWAFT with our electronic patient records. We don't have any more detail about the specifics of that at the moment. So hopefully the paper gives you a little bit of how we've come to this position and the need for us to receive that investment, both in terms of our new hospital, supporting our new hospital development, but in providing patient care every day. Just to give the committee assurance, we are able to care for patients safely every day. We have our own computer systems. We are digital in that we do use digital, we're not on paper as such, but it does not provide the core level of digital functionality that the NHS would expect, such as things like electronic prescribing or electronic documentation, patient portals, for example, that would support patients remotely, such as colleagues may be aware of in other organisations, such as Cambridge University hospitals. Thank you.
Thank you, Charlotte. Councillor Sanderson, is there anything that you'd like to say at this stage?
Got it. Thank you. Thank you, Chair, and welcome to your first meeting as Chair. I'd also like to thank Charlotte and colleagues for all the hard work they're putting into to trying to progress this issue. As Charlotte said accurately, prescribing, patient portal, things like that are not available. And I know that Adam Brooks do have that service, from what I understand, and of course, patients sometimes will go from MWAF to Cambridge hospitals, and they will at times probably find that frustrating and confusing, which is probably the last thing you need if you require healthcare. I just wondered if there's something that we can do as an authority to help progress things. I know MWAFT have got a very good steer on it, and we've had help from Ben as the local Member of Parliament as well, who's been asking questions in the House. Obviously, we do have a lot of data, social care. A lot of vulnerable people come our way as a local authority, and of course our partners at sort of district and city level will have data on people who are claiming benefits. So of course they also will have that as a potential database. So if there's anything we can do, certainly as an authority to assist NWAFT, I think that will be beneficial. I'm no IT expert, so I'm not sure how realistic that is. But and also I'd like to thank Councillor Howard as well, who started to progress this when I attended the meeting last time. Thank you.
Thank you, Councillor Sanderson. Patrick, is there anything you wanted to say on that?
I'm sure we could do some, in terms of the scrutiny committee after today's session, I'm sure we could offer some further support in response to helping that. But it seems that the funding gap's the biggest thing at the moment, amongst other things. So I think the scrutiny committee needs to explore what other options are available for NWAFT as an organisation and NHS around addressing that particular gap. Because as Charlotte says, it's a handful of acute trusts that haven't yet got patient records, electronic patient records. The council can support, and the scrutiny committee can support their work, but I suppose scrutiny needs to understand some of the more detail. So maybe there's a follow-up question at the end or a follow-up response from me once scrutiny's had a chance to ask some further questions.
Thank you very much. I'll open the scrutiny debate now, and I'll begin by taking questions on the 4 lines of inquiry that we discussed during the pre-meet. But I'd like to group the first 2 together just in the interest of time. So if members could hone in on the questions they feel are most relevant, that would be particularly useful. So the first 2 topics I'd like to discuss are funding, transformation and assurance, and data security and digital maturity. Do members have any questions for Charlotte? Councillor Horgan.
Thank you, Chair. Yeah, I'm going to focus in on this one. Section 1.7, the Trust says its legacy clinical portal cannot be commercially supported. So what is the risk assessment for operating an unsupported system, and what contingency plans exist if it fails?
Thank you for the question. So yes, it's absolutely right. We have an in-house clinical application portal. In-house. Can you hear me all right? Oh, thank you very much. That's saved me some neck strain. Thank you for the tip. We have an in-house developed clinical application portal. So of course we can tap into commercial resources to help to enhance it where we need to, but it's not a piece of purchase software from a named vendor who would underwrite and therefore warranty their product. Because we're living with the challenges of our existing systems for a lot longer than we anticipated due to the delays in funding, we are going through a program of clinical safety. So for each one of our 29 underlying main clinical systems, including this particular portal, we're doing a detailed clinical risk assessment to make sure that we understand where that links through, and that it's able to be accredited, understood, and is safe for clinical use, and that we understand and have a firm grasp for the risks. That will also help us when we eventually come to migrate away from our in-house developed application to a fully commercially supported platform in the whole organisation, which is our aspiration through the EPR program, electronic patient record program, because that will help us understand the risks of transition between what we've got now and R2B. But absolutely, we're going through an accreditation program to answer your point.
Well, what happens if it fails?
We have an in-house team. So this is common in my. So I've been working in the NHS for 20 odd years, and often when things are unable to be commercially supported, what does that mean? It means the in-house digital teams need to underwrite and take on the support. It means that sometimes it wouldn't be able to be recovered as quickly as possible, or you might experience a higher level of risk with it. But we've basically taken the support in-house.
Yeah, I think to be clear, the portal we're referring to is a sort of wraparound system that staff would use to interact and manage patient pathways. Our core patient master index is on a commercially supported product. So the management of sort of core patient identifiable information is on a core PAS. And we, in effect, loop together 28 systems to manage patients on a day-to-day basis. So the portal provides a convenient way to link that information together for staff, but those core systems obviously have their own safety and security within them. It's just that obviously it's very siloed, and so in terms of supporting a holistic management of patients, it creates a problem. Geraldine's right, we maintain that portal in-house, and as a result have to stay on top of updates, fixes, etc., etc. So it's also, for me and our board, a consideration not only of the supplier products that we purchase, but also our ability as an organisation to maintain and support the digital capability that we need through our team and through the capability that we have in the trust. And hence why one of the aims of our EPR programme is to partner with other organisations to allow us to have a more comprehensive digital team that can support more advanced technology and work with suppliers. Thank you.
Thank you. Councillor Howett.
As we've heard from colleagues, we seek in this committee to be constructive and try and support things to happen, recognising none of us are perfect. But I think one of our other roles is accountability. And you've had since 2021 to do this with an initial target of 2025. So I would like you to talk me through the timeline of what your board did from 2021 onwards, because it's a long time. It's a long time. And 97% of trusts this March had done it, which puts you in the bottom 3% nationally. I'm sure a lot of those other health trusts also hit bumps in the road, but they managed to steer over them. So what are the special circumstances that mean that you couldn't do it when so many others could? I hear what you say about procurement. We procure all the time, so we're very familiar with it and how it works. If one bidder didn't give you information to enable you to compare, surely that's their problem, not yours. And you choose the best bid on the basis of the bids that were put before you, or is it that you mismanaged the procurement process? In which case, I think you should be honest about that. I haven't heard that answer yet. Two more. The government, NHS England's frontline digitisation support offer was available in 2021 to provide finance to assist you to do it. By your own admission, you did access it in 2023-24. But is it true you've not had any resources from that yet in 2027, 26 rather? Is that really true? Because that seems a lot of time when money was on offer that you've not been able to take advantage of it. And finally, for those trusts that have done this, but have been found to not do it totally optimally, let's put it like that, there's bound to be an issue of public confidence on if you spent so long getting your act together to actually have the system that you might not operate it very well, and that patients' medical histories may not be completely in the system, and that could lead to medical negative impacts on patients that could be really quite serious. So how can you answer that patients should have confidence that when you do finally do this, that it will be done properly?
Thank you for those questions, and I appreciate that. And I may ask Geraldine to talk a little bit about the readiness work that we're doing to give assurance around your final point. Yes, indeed, the programme's been running for a number of years, and organisations have been sequenced into waves to support the adoption of electronic patient records across England. And it was in 2023, indeed, that North West Anglia worked up the first outline business case for our EPR. There's a very well-managed, very prescribed gateway process for assurance on that investment that we work with. So we have to pass, as you've heard in the paper, this criteria review for our suitability for that investment, the appropriateness of that investment, working with NHS England, which does take time. So it takes about 18 months or so to go through that process because of the spend, the supplier market, the capabilities and necessary requirements we have to fulfill from a digital perspective and from a financial perspective, and the strategic case we have to develop. In 2023, the organisation made a change to the programme because it was realised that perhaps we were not achieving the benefits that we could have done. So we were asked to revisit the benefits that we were articulating in the case. So we faced a delay there. We approached that case and went to procurement in the financial year 23-24. In terms of the procurement, to your point about mismanagement, we actually work with the London Procurement Partnership, who are experts in EPR procurement, to manage that for us. So we're asked to effectively use a best practice procurement process, which MWAF doesn't run independently. So we use the same procurement approach as mandated as best practice by NHS England. Obviously, we play a role in that, of course we do, and we make an assessment of the suppliers based on the quality, the affordability, and so on. And it's a complex market with multiple different options. So it's a very comprehensive procurement process. We have doctors, nurses, allied health professionals taking part in that. The way that the EPR, majority will be able to explain this much better than I, but the way that most of the digital infrastructure is moving in the health service is effectively to converge systems as much as possible to reduce the duplication and the reinvestment. So if you've got a big electronic patient record here and the trust next door wants to get an electronic patient record, there's a significant saving, so 20 to 30% saving from building one off the other effectively. So the strategy within NHS England has been to encourage organisations like ours to pursue a convergence agenda because it's more stable, it results in fewer commercial interfaces, and effectively it helps to standardise for patients and increase interoperability for patients. So we pursued that strategy. I think during the procurement, it became clear that that was quite difficult to compare financially. So the different convergence options, partnerships with different organisations, hosting of different computer systems in different places, complicated the financial aspects of that procurement. We felt that we were assured on some points, NHS England felt they were assured on some points, but the advice we received from NHS England was that it may not be a safe way to proceed. So I can't go into any more detail because we've just in a procurement process at the moment around the specifics. And obviously I can't be too specific because it would identify individual suppliers. But the nature of the procurement and the financial assumptions that were in there about the convergence, we weren't able to reach a position of safety. And so our board effectively decided to close that procurement and re-procure. So we then entered a process of going back to the market to re-procure, but by that time the national funding had closed. So what I can assure you is that we followed what we were reassured was best practice in terms of the procurement because it had successfully procured electronic patient record systems for other organisations like ours and was the current expertise backed with precedent and evaluation of EPRs, and that the board was very reluctant to take any steps which would delay our EPR, but we felt we were in a position where we had to do that on the assurance that we would have a further future opportunity to procure. So the whole process would be completing about now if we'd been able to proceed, but unfortunately we were not able to. To give you assurance, this is the top risk on our board assurance framework. The board receives an update on the electronic patient record every month. And we've made a non-executive director appointment to our board to support us with progressing this agenda because it is that serious to us and we appreciate the role that we've played in the programme. But unfortunately, we don't have control over the capital and revenue that's allocated to us through the Frontline Digitisation Programme. That's a sort of negotiation with the centre. However, it's not true to say that we haven't received any assurances of funding. We've been, I think it's about £5.2 million over the next 2 years to support us with readiness for the EPR and our programme that we're talking to you about today. That's been allocated to us in this medium-term plan spending review period. We're not in receipt of it yet, but we have effectively received an investment appraisal which would support us with that. So what we haven't received, and in my terminology, is what are we getting ready for? Because we haven't got a way to close the affordability gap on the actual purchase of an electronic patient record product at the moment. But we recognise that the world has moved on and that we may need to make more contributions or come up with different financial solutions to achieving that as a trust. So we will need to consider how we allocate our own capital and revenue over the next few years to try to make that more affordable. So I think we've largely been waiting through a national process. Now I think we're more into a collaborative process of funding between ourselves and the centre. And in terms of readiness, we are doing a lot to get ready for EPR. I know we haven't got a lot of time, Geraldine, but maybe if you could just give us a couple of points.
Yes, thank you. So clearly, to your point, Councillor, how from the time from 2021 until now, we have received some funding. It hasn't been the funding to take that step to award to the EPR vendor and to go forward, but we've been using it on preparing the business case. We've been using on mapping our existing processes, and we've been running for the last 3 years an infrastructure stabilization program. So, for example, Hinchinbrook Hospital used to the staff experience used to quite regularly drop out with connection problems or things going really slowly. We've resolved that, and we're now in a much better place to be ready across our multi-site organisation to actually run the capabilities that a fully modern EPR would require. That process, the funding finished in March of 2026, and so now we're in this uncertain new comprehensive spending review phase, and with the route to funding that we're negotiating through at the moment.
I do commend you for being candid. I think you've given full answers, and I do commend you for that. It is an issue of public trust and confidence, though. Can you say today when this actually will be done? In microphone.
No, I'm not in a position to give you a firm timeline of when we will go live with an electronic patient record at MWAFT. But we, as a board, have committed that we need to have a way forward to reach a certain level of digital maturity by 2029, because otherwise our new hospital is at risk. So I can give you assurance that we will make improvements to our digital maturity, whether that's through a comprehensive electronic patient record or otherwise, to enable us to be able to achieve the new hospital project at Hinchinbrook. So we will improve our digital maturity from its current status, and we will be making investments in that as an organisation over the next few years, as we've mentioned in our roadmap. So we will be making progress so we don't put our broader strategy for patients at risk, but I can't tell you when we will have a comprehensive electronic patient record that meets all the requirements of the NHS England Frontline Digitisation programme. We're not letting this hold us back from our modernisation work. So things like introducing artificial intelligence, I think mentioned, in order to improve our workforce experience. We're investing in our patient portals, we're investing in our cybersecurity, we're investing in our data platform to make sure that we've got data that links together, so we make sure we're prioritising the right patients. I can give you full assurance that those are commitments that we have made and will be taking financial steps to secure.
My only comment, and this is very brief, I think you should set a target date. 97% of other trusts have done it. You were asked to do it in 2021. In that answer, you said you'll still be looking at this in 2029. You've got £5 million of government money.
Yep.
I think for public trust and confidence, your board should set a date and make sure that you meet it.
Just to follow up quickly on that, we know what the race looks like from start to finish. The bit that we're in is getting to the start line. Those are the negotiations and conversations with NHS England. Once we have a way through those, we know exactly what the race looks like from beginning to end, because we've had extensive time to plan. But thank you.
Yeah, it's a fair challenge, and I think what we will need to do, pending the minister's letter of last week, once we establish what funding is available, will then be a matter of reprioritisation of our own capital assets, because obviously we have a local capital, so we would need to do a risk assessment effectively on things we don't spend money on in order to prioritise this, and that's exactly what we will do. I just can't tell you that work's been done as yet, so but certainly happy to come back to the committee to update on that once we've had the discussion at the Trust Board.
Thank you very much. Just to make the committee aware, Charlotte does actually need to leave now. So what I intend to do is to take verbal questions to the chair and take these away and send them to Charlotte and the team to make sure that we get a written response on everything that this committee wanted to scrutinise as an alternative to asking them live. Geraldine, you're welcome to stay, and if you are able to answer any of the questions that we have, I'd be more than happy to let you do that, but don't feel that there's an expectation on you to do so. So
My son's school is shutting early because of the heat wave, so apologies.
These things are unforeseen. You can't help it. The school is shutting early, and I'd much rather you were there to collect your son.
I'm happy to stay on to help the committee, and if there's questions that I need to take away, I'm happy to do that as well. Thank you.
Thank you very much, and thank you, Charlotte. So moving on to questions. Apologies, sorry, we had a question from Councillor Bulat that was waiting.
Thank you. I had a few questions on this theme, and I think most of them would probably require like coming back to committee with some answers. But of course, like feel free to comment on any of those, but don't feel pressured to respond. So obviously, it's a very difficult situation. I understand the affordability gap, but the more I think it's one of those things where the longer you live it, the worse it gets, and there's always something else that comes up, making it even less achievable. I do welcome some of the comments around the letter of support from the minister, some of the developments nationally as well. So there are some reassurances in that. However, I want to go back to the question of how did we get in this situation in the first place and around accountability. The report we had in front of us, which is really worrying to some of the timelines, some of the, I think, missed opportunities during the course of the last few years, does say the trust chose to pursue a locally developed digital function up to 23-24. That is the reason, in my view, why we failed to keep up with the digital innovations and actually not think about this sooner, including the questions that was mentioned before around, well, this cannot be commercially supported because the technical architect has retired. Why has, the single point of failure even been allowed when we're planning for such an important system? I mean, that was really shocking to hear in the report. So the question I had, which is mainly about accountability, is who made those strategic decisions to, first of all, rely onto this in-house bespoke system rather than adopting an established commercial EPR sooner in the trust? How was this point of failure be even allowed to exist in terms of relying on this technical architect to provide the support who has now retired? And of course, I appreciate the comments around the in-house team and support, but obviously that's not really good enough. How long has the board been aware about this non-compliance without taking any action, really? And also the comments around how, obviously, in the report we note it's a very low score in terms of the digital maturity assessment. So my question is around who is actually in the current leadership team even being held accountable, because it's all well and good to say, well, we're waiting for national funding, or that window has closed because legal challenges in procurement and so on. But surely someone in this process over those years need to just take responsibility to allow the system to basically degrade in a not fit for purpose state. So I just think it's really concerning. So my questions are just around, who is actually responsible and who is held accountable, and what can be done to prevent those same mistakes as we are now in this new procurement process, because I think it's really concerning. And as Councillor Howard said, I think it's a matter of public trust as well. Thank you.
Thank you. Yes, that's a really important question, actually. I echo the sentiment. I will like to take that question away, actually, if that's okay. Due to the nature of the question, I think it's appropriate we take that one and come back on it rather than put you on the spot there. Thanks.
Of course, thank you.
Are there any other questions that we'd like to verbalise that haven't already been written down? Councillor Horgan?
That's one that Geraldine may be able to answer. It's about the intelligent hospital capabilities for the rebuild. What capabilities cannot proceed without an electronic patient record, and what operational consequences will arise if the timeline slips further?
Thank you. So the national programme for the new hospitals, just to bring colleagues up to speed with that, the central teams within NHS England have mandated 49 intelligent hospital capabilities, as they're called. So the things like in the basement of a hospital, you might have an intelligently guided robot that moves logistics around, such as dirty linen or supplies or equipment that needs to be cleaned. And clearly, if that could be done automatically, as it is in some hospitals internationally, then that would be a great saving for staff's time and portering time, etc. So that's just one example of the 49 intelligent hospital capabilities. It's then for each local hospital like ourselves to then specifically define what we want to do with those. So at the stage we are in the planning for the new hospital programme, we are just embarking on the stage, it's called REBA Stage 3, which is a design and constructions phase. And we're embarking on the locally tailored design about which of these 49 what they'll precisely do for us. So some of that is still to come and is work in progress. However, we have identified in a workshop with the board that approximately a third of the 49 intelligent hospital capabilities require to some extent an EPR to work to their full extent. So a much more modern bleep system, for example, you'd need to have that. You need to have the business processes run through the digital capability to transport the messaging across a hospital. So we're working on that at the moment, but we think about a third of those 49 will be needed. With the EPR is on a critical path for full delivery and full benefit realization of them. To the question.
Thank you very much, Councillor Dr. Nawaz.
Yeah, thank you. Given that there have been some very well-known incidents of mega hacking incidents taking place with the banks and some very large commercial organizations, either for massive ransoms or for other commercial exploitation. And I think you would agree that the data held by the NHS is arguably the most commercially valuable and important data. So my question is, what measures do you have? And I am looking for some specifics without going into any sensitive technical matters. What measures do you have in place to assure the public that they are not vulnerable? Thank you.
Thank you. That's a great question. So in the NHS, there's 2 points of assurance. The first is a trust board member who's a CIRO, Senior Information Risk Owner. That's currently Richard Apps, who sits within our organisation with board accountability for both cyber and for information risk. He's our Director of Governance. And then the second is we have to do an annual return of something called a Data Security Protection Toolkit, the DSPT. We've been working on every year an improving plan. This year, for the first time in June, for the first time, we have fully met all the standards required in our Data Security Protection Toolkit return. So it's about strengthening identity access and controls. It's about increasing resilience against cybersecurity threats. And we work closely with the central NHS teams around this. So there's a big cybersecurity capability which is run by NHS England, and local trusts such as ourselves work closely with those to protect some of the national assets like the network, which could be a point of exposure for a cybersecurity threat. But I think we're doing significant amount in that space, and there are small amounts of funding which we're able to draw down as well. So, for example, we've managed to secure £250,000 to help us with further cybersecurity enhancements at the tail end of last year, and we're working on improvements in that space at the moment.
God forbid, should somebody succeed in penetrating your security, what measures do you have in place to damage control? Thank you.
Yeah, it's a great question. So just this year, for the first time, that Data Security Protection Toolkit is starting to shift focus from assurance to, it's called continuous data hardening. So I think for me, as a digital professional, the language and that's really interesting because it starts to talk about, it's not if the NHS has a cybersecurity incident, it's actually when. And it is exactly to your point, Dr. Was, about how can we be sure that we're going to recover? So it's about working with our emergency preparedness and response team, our EPRR team. It's about our trust board having cybersecurity on the risk register and being assured that the action plans that we have in place are adequate. Our trust board does cybersecurity awareness training every year. It's cultural as well as technical. So we might have the same is true in local authority, where you may have some social attempts to gain passwords or follow someone tailgating into a building, but we work a lot with that learning via the NHS England central team, how we can improve culturally and look to recover should we have a an attack such as this, which impacts clinical care.
I wonder if there is any benefit in anonymizing and codifying the data between the input and the end usage, where at the end it can be decodified to minimize the risk of it being compromised. Thank you.
Thank you. So data that's used at the moment, data that's used for direct care purposes, as in a clinician looking at an individual's patient record, is not anonymized, but patient data that's used for secondary purposes such as service planning, population health capability, and that tends to be, of course, larger volumes of patient records which are combined and therefore a greater risk to a greater target, if you like, for cybersecurity purposes. That's anonymized where possible. So as many of those controls as are practical, I would say, are built into the lifeblood of the way the hospital runs.
Thank you, Councillor. Thank you. So due to the nature of the time and the fact that we haven't had, I would say, the right amount of time to fully scrutinise this, I have the following proposal for the committee. I'd like to propose that we delegate authority to our Democratic Services Officer to collate all remaining questions and in conjunction with the Chair and Vice Chair, and then send these off to NENWAF to receive a written response. Could I ask members that if you do have questions that you send them to Democratic Services by Monday? I can't remember the date of Monday. You've got the, well, by Monday, midday, please. And we'll collate those by a point next week to get them off to NENWAF to get those written responses. Is everybody in agreement that that's how we proceed? Okay, thank you. In that case, then I'd like to draw that debate to a close. And thank you very much, Geraldine, for answering those questions.
You're welcome, and it's our pleasure. We've prepared written responses to questions that you very kindly shared in advance. So I think we're happy to share those as soon as possible, and also to take any further questions that people haven't had a chance to do today. And just finally, to the point that was made around how could potentially the local authority help. Clearly, our business case as it stands does have an articulation of benefits, which are benefits to the local health and the local population. So if required at some point, we'd be more than happy to sit down with any interested representative and go through those, and potentially there may be ways that they can be enhanced based on the experience and the work of the local authority. But we absolutely want to go through the next steps for our EPR journey very much in partnership. Thank you very much.
Thank you. And I do think the committee would like to take you up on that offer. So thank you. I also need to propose that we follow the previous practice and delegate authority to the Democratic Services Officer in consultation with the Chair and Vice Chair to produce a summary of our feedback and recommendations and send those to the relevant parties as well. So are we happy to agree that unanimously? Fantastic. Thank you very much. Can I just check with our Democratic Services Officer, is there anything else we need to conclude that? That's fine. Okay. In that case, then I'll draw the meeting to a close and thank you very much for your attendance.